Welcome to the deep dive. We've got quite a stack of material here, research papers, articles, clinical notes, all digging into personality disorders. It's a pretty complex area, often misunderstood.
Definitely complex.
Yeah.
And yeah, a lot of misconceptions out there.
So our mission today is to, well, cut through some of that complexity. We want to unpack what these patterns actually are based on these sources.
Right, what defines them.
Exactly, and then explore what the research suggests might cause them, or at least contribute. We'll also get into the challenges of diagnosis. Sounds like that's not always straightforward.
It rarely is, honestly.
And then treatment. We'll look at approaches, especially focusing on borderline personality disorder, BPD, and a therapy called DBT that comes up a lot in this material.
A very important therapy to discuss, especially for BPD.
Yeah, and the sources hint at some surprising insights too, things that go beyond the usual understanding. Okay, let's dive in and unpack this.
Sounds good. So, starting with the basics, what are personality disorders? The sources consistently define them as these enduring, deeply ingrained patterns.
Enduring that seems key.
It really is.
Yeah.
We're not talking about a bad mood or a reaction to a specific event. It's a pattern of inner experience, thoughts, feelings, and behavior that's pretty different from cultural expectations.
How different?
Significantly different. Enough that it causes problems. It affects how someone thinks, feels, relates to other people, manages their impulses.
Okay.
And crucially, these patterns usually show up by adolescence or early adulthood. They're inflexible, meaning they don't change much depending on the situation, and they lead to real distress or problems functioning in life.
So, pervasive and causing trouble, not just a personality quirk.
Exactly. And the main classification systems, the DSM, the ICD, they try to organize these. The sources mentioned they group them into clusters.
Right, the 3 clusters, based on similarities.
Yeah, descriptive similarities, though, there's always debate about these categories. But generally, you have cluster A, the odd or eccentric group.
Okay, what falls into that?
That includes paranoid personality disorder. Think deep suspicion, mistrust. Schizoid personality disorder, more about detachment, lack of interest in relationships. And schizotypal, characterized by social discomfort, maybe odd thinking, eccentric behavior.
So, people who might seem a bit aloof or have unusual perspectives.
That's a fair way to put it.
Uh-huh.
Then comes cluster B. This is the dramatic, emotional, or erratic cluster. Probably the most widely known, perhaps.
What's in cluster B?
Here you have antisocial personality disorder, disregard for others, rules, rights, borderline personality disorder, which we'll talk more about, lots of instability in relationships, self-image, emotions, plus impulsivity.
Okay.
And histrionic personality disorder, needing to be the center of attention, often dramatic.
Yeah.
And narcissistic personality disorder, grandiosity, needing admiration, lack of empathy.
That cluster sounds like it involves a lot of intensity, especially in how people relate to others.
It certainly can. The traits often involve heightened emotions or significant interpersonal difficulties. Finally, there's cluster C, the anxious or fearful cluster.
Anxious or fearful, like...
Avoiding personality disorder, extreme social inhibition, feeling inadequate, hypersensitive to criticism, fearing rejection. Dependent personality disorder, a real need to be taken care of. Submissive behavior, fear of separation, and obsessive-compulsive personality disorder, OCPD.
Ah, OCPD. The sources make a point of distinguishing this from OCD, right? That's a common mix-up.
A very common one, and it's important. OCPD is about a pervasive preoccupation with order, perfectionism, control. It's part of the personality structure. Often the person sees these traits as positive, or at least necessary.
Whereas OCD involves...
OCD involves specific obsessions, intrusive, unwanted thoughts and compulsions, repetitive behaviors done to reduce the anxiety caused by the obsessions. People with OCD are usually distressed by their symptoms. OCPD is more about a rigid way of being.
Got it. That distinction is really helpful. And I guess even with these clusters, everyone's experience is unique.
Absolutely. They're broad categories. Individuals are complex. Okay, so if that's what they are, the next big question the sources tackle is, why? What leads to these patterns?
And it sounds like there's no single answer. It's complicated.
That's the main takeaway from all the research cited. It's consistently presented as this complex interplay. Think genetics, environment, life experiences, all weaving together.
Nature and nurture, basically. What about the biological side? Did the sources mention specific brain findings?
They did. Some interesting links. For instance, findings connecting things like higher dopamine levels and enlarged ventricles in the brain with schizotypal personality disorder. There are some overlaps there with findings in schizophrenia research.
And I remember reading something about serotonin. linking deficits to antisocial and borderline PDs.
Yes, that's highlighted. Reduced serotonin activity is reported in both. That potentially combined with less efficient functioning in the frontal lobes, especially the prefrontal cortex, which helps with control and planning.
Impulse control, decision making.
Exactly. And maybe an overly reactive amygdala, the brain's threat detector. Well, that combination could contribute to the impulsivity and aggression sometimes seen in those disorders.
Wow, that paints a picture of how brain function might directly influence these core traits. The sources also reminded us to rule out medical causes, too.
Crucial point, clinically. Personality changes can be caused or worsened by things like head injuries, neurological diseases, even endocrine problems. So a thorough medical check is part of the assessment.
Makes sense. Okay, shifting to psychological factors. The material really emphasized early life experiences, drawing on psychodynamic ideas.
Yes, there's a strong theme in the sources linking negative early childhoods. Things like significant stress, poverty, chaotic homes, witnessing violence, neglect, abuse, parental rejection to later difficulties, including personality disorders.
It feels intuitive that really difficult early years could shape personality development in challenging ways.
And the sources specifically connect experiences like parental loss or rejection in childhood to the intense fear of abandonment that's so central to borderline personality disorder in adulthood.
That connection seems very direct.
There's also the idea that maybe some PDs, like avoidant, could stem partly from simply not developing typical social skills during childhood or adolescence.
Right. And what about the broader social context? Family, community?
Family dysfunction comes up repeatedly. High levels of conflict, stress, poverty, unemployment, family breakdown, witnessing domestic violence, these are frequently noted in the backgrounds. Correlational studies mentioned suggest links between things like poverty, unemployment, lower education levels, and higher rates of PD diagnoses. It suggests disadvantage can increase vulnerability.
So it really sounds like a convergence, maybe some biological vulnerability plus difficult early experiences, maybe in a tough social environment. It all adds up.
That's the picture the sources consistently paint. It's rarely just one factor.
Okay, let's zoom in now, as you said, on borderline personality disorder, BPD. The material gives it a lot of attention, and it seems to exemplify these complex dynamics.
It really does. BPD is defined by that pervasive instability in relationships, self-image, emotions, alongside significant impulsivity.
And emotional dysregulation is highlighted as a core feature. What does that actually feel like or look like?
It's described as this fundamental difficulty in managing emotional states. So emotions hit with incredible intensity, they last a long time, and they often feel way out of proportion to the trigger.
Like an emotional volume dial turned way up.
Exactly, and stuck there. The sources talk about affective instability, rapid, intense mood shifts, like emotional storms that blow up quickly, often triggered by perceived slights or fears of abandonment.
And hard to calm down from.
Very hard, a slow return to baseline. Plus, there's often increased sensitivity, especially to negative emotions, and maybe a negativity bias, focusing more on potential threats or negative cues from others.
That sounds utterly exhausting and painful.
It's described as incredibly distressing. That sheer intensity can feel unbearable. And the sources suggest that sometimes behaviors like self-harm or suicidal actions might be, in part, desperate attempts to cope with or escape that overwhelming internal pain.
So potentially a coping mechanism, however harmful, rather than manipulation. That's an important perspective against common stereotypes.
It is. The focus in the sources is often on the internal experience driving the behavior. They mention specific types of dysphoria, common in BPD, intense emptiness, emotional pain, feeling fragmented or losing your sense of self, feeling victimized, often linked to perceived betrayals.
How does all this internal turmoil play out in relationships? They're described as unstable.
Relationships are often really challenging. The material mentions high rates of stress, conflict, dissatisfaction, and sadly higher risks of things like domestic abuse and unintended pregnancies. Relationship patterns are sometimes described as butterfly-like, intense but fleeting or attached, fewer but very intense, dependent, and often stormy.
And the sources are very clear. Self-harm and suicidal behavior aren't just side effects, they're part of the core diagnosis.
Yes, explicitly listed in the DSM-5 criteria. The statistics mentioned are stark. 50–80% engage in self-harm. Cutting is common, and the lifetime suicide risk is tragically high, estimated at 3–10%. There's even a finding suggesting undiagnosed BPD might be involved in a significant number of male suicides.
Wow, that underscores the seriousness. and the need to take any self-harm very seriously in treatment.
Absolutely. Parasuicidal behavior always requires immediate clinical attention. This severity also shows up in healthcare use. People with BPD tend to have more hospitalizations, more ER visits than other PDs, often linked to suicidal crises.
It's clearly a condition of intense suffering and difficulty. The sources even mention subtypes, like Millen's ideas.
Yeah, Theodore Millen proposed subtypes: discouraged, impulsive, petulant, self-destructive, based on which other traits might be prominent. Just highlights the variability even within the BPD diagnosis.
Okay, so given how complex and intense BPD and other PDs are, it's maybe not surprising the sources spend time on how difficult diagnosis actually is.
Definitely not surprising. The material makes it very clear that using the current systems, DSM and ICD, to diagnose personality disorders comes with real challenges.
What kind of challenges?
Well, for one, there's a lot of overlap. Someone might meet criteria for several PDs at once. Makes it messy.
Right.
The categories don't always capture the full picture of someone's struggles, leading to many not otherwise specified diagnoses. Then there's reliability. Clinical judgment can vary. Self-reports might exaggerate issues, structured interviews are better but time-consuming, and different assessment tools sometimes disagree.
So getting a clear, reliable diagnosis can be tough.
It really can be. And a key point raised is that even when you get a diagnosis, the current categories often aren't that helpful for figuring out the best treatment, which is, usually the goal.
That seems like a major limitation. The sources also mention something about breadth and depth.
Yeah, the idea that some PDs, like BPD and antisocial, seem to cover a wider range of traits, more breadth, while others, like maybe paranoid or OCPD, feel more focused on a core trait, less breadth, just adds another layer of complexity.
And there's this whole debate discussed about immutability, whether these are truly fixed lifelong conditions.
This raises an important question. If diagnosis is so challenging, and the conditions themselves are complex, how effective can treatment really be for these deeply ingrained patterns?
That's the crucial question. But the follow-up studies mentioned, especially for BPD, seem to challenge that old idea of them being totally fixed, right?
Exactly. Some research shows that over time, particularly with treatment, individuals can experience enough change that they no longer meet the full criteria for BPD. They can achieve periods of stability and wellness.
But there's a counter-argument suggesting maybe a core vulnerability lingers.
Right. Some critics suggest that even if overt behaviors change, an underlying predisposition, maybe a diathesis, might remain. This could make someone more vulnerable to slipping back into old patterns, especially under stress.
Which leads to this idea of maybe thinking about episodes of being personality disordered rather than it being constant from day one.
It's a different way of conceptualizing it, yeah.
Yeah.
Less about a fixed state and more about a vulnerability that can be triggered.
Interesting. So, practically speaking, who makes these diagnoses and when?
It's licensed mental health professionals, clinical psychologists, psychiatrists. They use a full history, observations, and the DSM-5 criteria. Usually it's not diagnosed before age 18 because personality is still forming.
And people don't usually walk in asking for a PD diagnosis.
Rarely. More often they seek help because of the consequences. Relationship breakdowns, job losses, overwhelming anxiety, deep depression. They want relief from the suffering the patterns cause.
Makes sense. Okay, let's flip to the treatment side. What do the sources say works? Is there hope?
There absolutely is hope. The sources emphasize that personality disorders are treatable, and most treatment happens in the community, not hospitals. The main approach is psychotherapy, talk therapy.
Different kinds?
Yeah, various types. Individual therapy, group therapy, family therapy sometimes, psychoeducation to understand the condition, even self-help resources.
What about medication? Is that part of the picture?
It can be, but the sources are careful here. Medication is not the primary treatment for the personality disorder itself. There aren't any FDA-approved drugs specifically for PDs.
So, they're used for
specific symptoms or co-occurring conditions, like SSRIs might help with associated depression or anxiety or sometimes impulsivity. Mood stabilizers might target mood swings or aggression. Occasionally, low-dose antipsychotics for intense anger or transient psychotic symptoms.
But with caveats.
Definitely. The evidence for meds directly helping the core PD traits is mixed. There are side effect risks, addiction potential, especially with benzodiazepines, which are generally discouraged, and overdose risks. The recommendation is usually conservative use, alongside therapy, not as a replacement.
Okay, so therapy is key. And this brings us to dialectical behavior therapy, DBT, which gets a lot of focus for BPD in these materials.
Yes, DBT is really highlighted. developed by Marshall and Ham specifically for individuals with BPD, particularly those struggling with suicidal behavior and self-harm. It comes from CBT, cognitive behavioral therapy, but it's adapted for people who experience emotions very intensely.
And the name dialectical, what's that about?
It refers to its core idea, balancing opposites, specifically the dialectic between accepting yourself and your reality as it is right now, without judgment, and change, the need to learn skills and make changes to build a better life, holding both acceptance and the need for change at the same time.
Acceptance and change, and the sources say it's effective.
Very effective, particularly for BPD. It's described as the treatment with the most robust empirical support, based on randomized controlled trials. And its principles and skills are also helpful for other issues involving emotion dysregulation, self-harm, PTSD, substance use, eating disorders, even depression and anxiety.
So the goal is building healthy coping skills to replace the unhealthy ones. How is DBT structured? The sources mention components.
Right. Comprehensive DBT typically has 4 parts. First, there's the skills training group. Usually weekly, it's like a class teaching specific behavioral skills.
What kind of skills?
They fall into 4 modules. Core mindfulness, learning to be present and aware. Interpersonal effectiveness, navigating relationships, asking for what you need, saying no. Emotion regulation, understanding and managing intense emotions. And distress tolerance, getting through crises without making things worse. There's homework, practice, diary cards to track things, often recommended for at least a year.
And individual therapy too.
Yes, usually weekly individual sessions. This is where you work on personal goals, troubleshoot applying the skills, and address any behaviors getting in the way of therapy itself.
Then there was telephone coaching. Sounds intense, but important.
It is. It allows the person to call their therapist between sessions for brief, in-the-moment coaching on using skills during a crisis. It's designed to help generalize skills to real life and reduce reliance on harmful behaviors like self-harm. Therapists set clear limits, but it's seen as a key part of reducing crisis behaviors.
And the last piece, support for the therapists.
Exactly, the therapist consultation team. Therapists doing DBT meet regularly to support each other, ensure they're sticking to the model, manage their own stress, and basically stay effective. It's demanding work.
Can we just quickly revisit those skills? Mindfulness is central.
Absolutely core. It's about paying attention on purpose in the present moment, non-judgmentally. It helps create space between a feeling and an action, allowing for more skillful responses.
Interpersonal effectiveness, that's about relationships.
Yep. Learning to assert needs respectfully, manage conflict, build and maintain healthier relationships can really reduce interpersonal chaos.
Emotion regulation, distress tolerance, pretty self-explanatory.
Largely. Emotion regulation skills help you understand your emotions, reduce vulnerability to negative ones, and change unwanted emotions once they start. Distress tolerance is about surviving crises, accepting reality when you can't change it immediately, without resorting to impulsive or harmful actions. There are also skills focused on building self-respect.
It sounds incredibly thorough and practical. And you mentioned addressing therapy-interfering behaviors.
Yes, DBT directly targets behaviors that might derail treatment, like missing sessions, not doing homework, hostility towards the therapist. Addressing these is crucial for keeping people engaged and making progress.
Given the trauma link we discussed earlier, do the sources mention integrating trauma-informed care?
They do. They acknowledge the high rates of trauma, especially childhood trauma, among those with PDs like BPD. So trauma-informed principles, safety, choice, collaboration, empowerment are important. And therapies like CBT, DBT itself, and EMDR can be used to carefully process trauma when the person is ready.
And mindfulness practice, even outside DBT, seems promising.
Yeah, the sources mention studies linking general mindfulness meditation to positive brain changes and symptom improvements. It seems to be a helpful tool.
That's all quite encouraging, especially the part about potential long-term improvement for BPD with treatment.
Yes, the outlook presented is much more hopeful than it used to be. Studies suggest that with effective treatment like DBT, maybe up to half of individuals diagnosed with BPD show significant improvement over about 10 years, potentially to the point of no longer meeting diagnostic criteria. DBT is considered first line, often reducing the need for hospitalizations or crisis care.
That really underscores the value of accessing the right support. Okay, just briefly, let's touch on prevalence and impact before we wrap up.
Sure. Global estimates mentioned hover around 6–9% of the population having a personality disorder, but it's higher in clinical settings, naturally. Demographically, often higher rates in younger adults, unmarried individuals,
Yeah.
lower socioeconomic status, though some conditions tend to lessen with age.
And the impact is significant.
Absolutely.
Yeah.
Significant personal distress, family suffering, major difficulties in work, social life, relationships. But there was also that surprising finding in the sources.
Right, the one about certain traits.
Yeah, the traits associated with histrionic, narcissistic, and OCPD were found in some studies to be potentially more common in samples of high-level executives than in disturbed criminal samples.
Things like charm, confidence, perfectionism, rigidity. It's wild. It really shows how traits manifest so differently depending on context and how complex personality is. Not just black and white, disordered or not.
Exactly. It challenges simple stereotypes.
Wow. Okay, we have covered a lot of ground. From defining these complex conditions, exploring their tangled origins, really zooming in on BPD, grappling with diagnosis, and then looking at effective treatments like DBT.
And I think if we connect this back to the bigger picture, understanding personality disorders isn't just about the labels, it's about recognizing these deeply ingrained patterns that cause real suffering, but also knowing that effective, evidence-based help exists. Change is possible.
So, what does this all mean for someone listening? It means that while these conditions are incredibly challenging for the person experiencing them and those around them, they aren't necessarily a life sentence. There's genuine hope. Therapies like DBT offer concrete skills and pathways towards managing emotions, improving relationships, and building a life they find meaningful.
Absolutely. The potential for recovery and significant improvement is real.
And maybe a final thought to leave you with based on our discussion. Given that debate around whether personality disorders are fixed forever versus being more like a vulnerability that flares up under stress, how might it shift our perspective if we thought about these struggles sometimes as episodes of vulnerability rather than only as lifelong, unchanging diagnoses? How might that change the way we offer support, or even just how we understand people facing these challenges? Something to think about.